Welcome to the Prescription for Admission podcast, where we talk about hospitals and hospital-based care, who you can expect to meet, and what you may experience during your time in the hospital, both as a patient and also as a healthcare provider working in a hospital. My name is Dr. Monique Nugent. I am a practicing hospitalist and also the author of Prescription for Admission, the book, where I talk about many of the same topics. Thank you for joining me and enjoy the show. Hi, and welcome back to another episode of the Prescription for Admission podcast. I am your host, Dr. Monique Nugent. I am a working practicing hospitalist and also the author of Prescription for Admission, the book, where I dive into a lot of these topics. But the fun thing about this podcast is I get to bring on guests to talk about my favorite thing, hospitals. All things hospitals, all things inpatient care. And today is a really exciting episode. We are joined today by Dr. Julie Siemers. Dr. Siemers, thank you so much for being here.
You're welcome. Happy to be here. Thank you.
Thanks. I'm just going to take a little bit of time to introduce you because I really want you to know that we have an expert with us today to talk about safety. Really, really big thing. So Dr. Julie Siemers is a patient safety consultant, industry nurse leader, educator, and TEDx speaker. She's also the founder of LifeBeat Solutions and the author of the best-selling book, Surviving Your Hospital Stay, a nurse's educator's guide to staying safe and living to tell about it. Dr. Siemers holds a Doctor of Nursing practice degree from Touro University in Nevada, and she brings more than 4 decades of experience and expertise in nursing practice, education, and executive leadership in the healthcare arena. Julie, thank you so much again for being here to share that wealth of knowledge that you have with us.
Thank you. I'm happy to share with your audience. Hopefully they'll learn something new today.
Oh, yes. Because I think people are probably tired of me saying the number one thing I want you to be in a hospital is safe. And today we're going to talk about why I say that over and over and over again. But before we get into that, you've been doing this for, like I said, 4 decades. That's a long time to build a career in healthcare. How did you get to this place in your career?
I never thought I would end up here, but that's what's exciting about the healthcare journey, right? Yes. So I started out on the med-surg floor for quite a while, worked oncology and cardiac step down, and then went to the ICU and then the trauma center. And then I spent 10 years as a flight nurse on the helicopter.
Oh, that's so cool.
So yeah, it was really a lot of fun. It was challenging because, of course, you never know what you're going to find when you arrive to help this critically ill patient. And then in 2009, I decided I've learned a lot and I really want to share with nurses going into this field, and hopefully I can help shape the future of healthcare. So in that, I started on my master's and then my doctoral degree. And the subject I chose kind of accidentally was patient safety. And I stumbled across it because of hearing so many stories of patient harm. And it just really perplexed me why we don't really talk about it. And I had no idea it was such a huge issue. I just didn't. I was like, how could I have not known that?
Yeah. I don't think that people think about safety at all in a hospital because they assume they are safe.
Yes.
In fact, there's oftentimes people come to the hospital because they feel it's the safer place to be than home, right? And I understand that. And that's not the point of this conversation, to scare you away. In no way, right? Hospitals are aware that safety is a big issue, and there's a lot of resources devoted to it, a lot of people who are dedicating their careers like you to it, mandates from the government, mandates from insurers. So it's on the top of everyone's mind. And it's everything. I want people to understand it's everything from a slip and fall, right, to medication errors, to leaving the hospital with the wrong document. Safety isn't just, and I think we think about healthcare, we think these really extreme things, like they cut off the wrong leg, right? That's not, that's clearly obviously horrible. That's not the only horrible, bad safety thing that happens.
Right.
And it can happen at any point in your hospital. Say, I once discharged a patient who did really well in her hospital stay. And she really didn't want to wait for someone to come bring her down in a wheelchair. And not everyone has to leave in a wheelchair. I think people think like that happens on television, and so everyone must go to the front in a wheelchair. A lot of people are quite capable of walking and safely. And this person was wearing flip-flops and ran to catch the elevator. Like, the person who was picking them up was holding the elevator going, come on, come on, come on. Ran to catch the elevator, slipped in their flip-flop and broke a bone after being discharged from something totally not related and doing really well. And now we have literally, I just like readmitted the patient. Right.
Yeah.
And for me, like, it was such an unfortunate thing because it was like, you were just out the door. Right. And so the safety is from door to door. From the second you come in to the moment that you leave, we have to be aware of your safety, and you have to be aware of your safety.
Yeah, it is. And again, I also don't want to scare people, but I want people to be aware that you have to be an active participant in your health.
Yes.
Because doctors and nurses can't keep all of the balls juggling in the air and not drop one here and there. And again, it's humans that make the errors, but it's because of systems that have gaps and holes, and when those systems align for a mistake. All I'm saying is to be informed and educated is going to be your best tools and strategies to stay safe. And yes, doctors go to school for 12 plus years, and nurses go to school for 2, 4, or 6 years. And yes, we have that education that you as a layperson don't have. But what you have that we don't have is the nuances of your family member or yourself.
Yes.
And saying, hey, I know my mom's 75 years old, but she's never confused what's going on. Yeah. And as a nurse, I may say, oh, well, maybe I assumed, that she was usually confused. But if this is new, we need to figure out, is her blood sugar low? Is there oxygen low? Those types of things.
Yeah. Yeah. You said it. You have to be an active participant. And being an active participant often means having another set of eyes or ears. I advocate for people, try not to come to the hospital alone.
Yeah.
Because you're coming in, you're sick, you're uncomfortable, you're in pain, you're vomiting. And then I show up and I'm like, tell me your life story. Between the vomits. Like, it's hard. It's hard to fill in the gaps. My favorite is always on discharge when we're like, okay, ready to go. We're talking to someone's loved one and we say, okay, dad's ready to go. And they'll say, like, did he tell you he has 8 steps to get upstairs? And we're like, you have 8 steps? But that's safety too, because safety in your home is vital for your success to not be rehospitalized. And I want people to also understand that it's not just what I said, these big egregious things. The most common error in a hospital is medication.
Yep. Mm-hmm.
Right? It's not chopping off the wrong leg. It's a medication error. And what is a medication error? It's not just that you got the wrong medicine. It's not that you got your neighbor's medicine. That is clearly an error. The wrong dose is an error. The wrong time is an error. Too much, too little. Did it interact with something? Did you have an allergy to it that we weren't aware of? All of those things go into, your safety,
Yeah. Yeah. And I think I suggest to people always ask if the nurse is bringing in a medication or the doctor orders a medication. What is this for? What should we watch for side effects? What are we expecting it to do? Because so many times a patient will say, I already take a blood pressure medication. What's this one? And it gives us the opportunity to pause and double check. Are we double dosing them? Are we, like you said, giving them a medication that may interact with something that they're already taking? I think that's super important. The other thing that I talk about is 70%, and this is from the Joint Commission, 70% of patient harm events are due to communication breakdowns. So whether that's between the physician to physician or physician to nurse or family, it is included in that mix too. And that's why I always advocate for your your loved one by speaking up and saying something's wrong, something doesn't look right, or I'm concerned.
So you brought off two of my favorite things. I think we should dive into them. One is, what is JACO? What are the bodies that look out for safety in hospitals and hospitals report to? What are those bodies, and why should we know about them and care about them?
Yeah, Joint Commission it's not a federal agency for your
Nope.
audience. It is a private organization that accredits hospitals, and the reason they need to be accredited is to make sure they get the funding from CMS, Center for Medicaid and Medicare Services. So there's guidelines that each of them have to remain accredited once they are accredited, and then to make sure that their reimbursements through CMS are that they're not suffering penalties and that they're actually getting the reimbursements when they give good care.
Right.
So I think those are two of the biggest things, is understanding the job function, so to speak, of those two agencies.
Yeah. And so hospitals work really hard to maintain that accreditation. And when JACO comes, Joint Commission, sorry, they used to be called JACO, but they're now the Joint Commission. When Joint Commission comes, it's a total look at how the hospital is working, every aspect of the hospital, to make sure that patients are safe, the quality of care is high, and there is faith that this hospital is able to care for patients. So I know that they literally check everything from how the sterilizers are working, right, to are your docs finishing their documentation on time, right? And if you think about that, all of those things are clearly safety issues. People will think about the sterilization thing as a safety issue. That's not the only safety issue, right? If I don't finish my documentation in time and you walk out the door without something that clearly communicates to your primary care doctor, to your loved ones, to the skilled nursing facility, what you need to do, that is a safety issue too, because that's a transition of care. Again, I'm like a hospital nerd. I get excited talking about things like transitions of care. And that's exactly what you were talking about. Transitions of care. I'll define that for our audience. It's a point in your healthcare where your care goes from one team or one person to another, right? From one place, and that can even be in the hospital, from one place in the hospital to another. When we think about transition of care, big times from outpatient to inpatient, from coming home, from being at home and coming into the hospital, and then other times from being in the hospital and going home. But you spoke about handoffs. That's a transition of care. Me speaking to my colleagues, the nurse speaking to her colleague at change of shift, giving sign out, right? Are we communicating, and do we have the tools to communicate your needs safely?
Yeah, and that's why I always recommend to patients and their families to bring a notepad and take notes, because even though we're well intended to communicate everything that's pertinent, sometimes things fall through the cracks and get lost. And that way, as an advocate for your family member, you can say, oh, well, the doctor yesterday said, or this happened yesterday. Were you aware when they took this medication, or whatever that may be? Again, that's that communication for continuity of care, like you talked about. But yes, I know there's statistics and studies out there that talk about that transition of care is the most vulnerable time for a patient, because we think we're hitting all the highlights, or we think we're going to document all those. But again, documentation can be in different parts of this electronic health record, and they may not come to the awareness of the next provider, right?
Yeah. And so I spent a lot of time as a resident, intern orientation. We spent a lot of time learning to give sign out to each other, and I work with medical students now, and we also do that practice, learning to give sign out, where I walk up and I say, this is Mrs. Jones. She's an 86-year-old female. She's here for a broken hip, diabetes. I learned to hit the high points. I learned to make sure I'm communicating. And I also learned to question, oh, what do you mean she has diabetes? When was the last time you changed her insulin? Because I know she's supposed to be NPO tonight. Things like that, right? But that practice is not just it's not something that we do to each other as family members. We don't learn to own that information. And that's what I really tell people, like, own your information. Like Julie was just saying, take notes, bring notes, be the person who's communicating, and feel empowered to give me the pertinent information and ask the pertinent questions on at any point in time, so that we are in that fair dialogue. Because the only thing we have to gain is safety. That's really, and when we're not worried about you being safe, we can focus on you being comfortable. We can focus on making sure your plan is efficient and all of these things, because we have the confidence that we know that you're safe. And so, yeah, be an advocate. I once met a family who they were caring for their elderly parent with dementia, and they told me they use Google Docs, a shared Google document that the siblings would update. So, if one went to an appointment with mom, they would change the medication list in Google Doc. And if one stayed overnight, they would put a little note as to what happened overnight. And I was like, wow, this family this family had a great idea. And they had a consistent tool. I always talk about people who walk around with binders. I love those people. But like nowadays, if you can find technology, a way to make it accessible to yourself anytime. I tell people, if your primary care has an app that has the most updated medication list, please bust that out. Like, show me.
No.
I want to see it. I want to see it. That's exciting. So what is it that you want people to understand about hospital safety? Like there's so many things. I know that was a big question.
I think, as we were talking about earlier, communication is so essential. And I think we live still in a culture of this hierarchy. And a lot of times family members will feel intimidated to speak up. Mm-hmm. As we said earlier, because, the doctor has so much education and the nurse has so much education, and what do I know? But I think if we look at it as a partnership, that we have a lot to contribute as family members. Mm-hmm. And that's why I did my TEDx on the topic I did. I mean, it was titled How Not to Die in the Hospital, but really the whole conversation was about how do we protect patients, and it's that synergy of mm-hmm. the partnership of healthcare providers and family members that we work together. And so, yes, you may run into providers that aren't welcoming questions, or may, a nurse may not know when you ask a question. And I always teach my students, the only dumb question is the one you don't ask.
Yeah.
And healthcare providers are never going to know it all. And so, if you've done your research on whatever medication or disease or whatever, it should be a two-way conversation. And I think that's a really important point. The other thing I talk about is the cuss words. And so it's concerned, uncomfortable, scared, and I feel like this is a safety issue. And so
I love it.
Yeah, those kind of are cues, should be mm-hmm. cues that you know something or feel something, even if you can't put your finger on it, and communicate. I'm really concerned. My mom's foot, she just had knee surgery and now her foot is cooler than the other one. Is that normal? Because I'm concerned. And just having the courage, even though it may feel intimidating, just get the courage to speak up, because you never know what you're going to say that would make the healthcare provider say, oh, I didn't notice that. You're right.
Yeah. It is a team effort. Your family member better than us. I spend time speaking to pediatricians on the podcast, and almost each and every one of them says, your child better, right? And it's the same thing if you're a caretaker, if you're a loved one, this person better than us. I personally love when family members are at the bedside, because I get that extra set of eyes and ears. We have immediately a family meeting. I don't have to try and make a phone call later in the day, right? And we address things in real time. And I jokingly say that they tell on my patients. The family members will tell me the thing that's happening, and they're like, I'm like, how are you doing today, Mr. Jones? He says, oh, I'm great. He had diarrhea all night. I'm like, okay, thank you.
Real information.
Yeah, I love it. It's a team effort, and your loved one will, trust me, they will appreciate that you were there to be a team member, to be that extra support, because we've got to maintain safety.
Yeah.
So we're not just speaking to patients. We also are speaking to healthcare providers on this podcast. And the thing that I want people to understand is that safety is all of our responsibility in a hospital.
Collective.
It is a collective thing. Should people feel intimidated to speak up about a safety event that they see in their hospital?
That's a really good question. And here's how I feel about healthcare. We need more transparency.
Yes.
We need not just in a slogan of just culture, but we really need to practice a just culture.
Yeah.
Because we are humans and we're going to make mistakes, and we hope they're not devastating to a patient. But, let's just take the Redondevat case from several years ago when, yes, it was horrific that she gave a paralytic instead of, the anti-anxiety medication.
Do you mind just recapping that case?
Oh, sure.
Yeah.
Yes. So this was at a hospital in Nashville, a real well-known one. And the nurse was floated down to the radiology department, never worked there before.
Yeah.
The patient that came in that needed a CAT scan had a head injury, but still was awake and talking. And she said to the nurse, "Oh my gosh, I'm so claustrophobic. I don't know if I can go in that CAT scan." And so they got an order for Versed, and the nurse did an override in the automatic dispensing cabinet and pulled out the wrong medication, which she injected into the patient. There was no monitoring done while the patient was in the CAT scan for 30 minutes. And when they pulled her out, she had stopped breathing because she was given a paralyzing agent. And so when we do the root cause analysis and really look at what happened, there was, like we talked about earlier, systems failures that really dug into, but they didn't want to be transparent with this because they wanted to cover it up and just have it go away, because we know we should be given excellent health care. And when that doesn't happen, we don't want people to know about it, but then we don't learn from it either.
Yeah.
And so they found this nurse was also orienting a new nurse, had never worked there or had an orientation. Doing an override in the system became a workaround for the nurses because the system wasn't functioning correctly in all of the hospital areas.
Yep.
And this hospital did not have a policy, this is just to name a few, for monitoring patients even getting Versed, which we know with Versed, the heart rate can drop, the blood pressure can drop, the
oxygenation can drop.
Exactly.
Yep.
And if you're not monitoring a patient for 30 minutes after giving that medication, even if that was the correct medication that was given, still patient can deteriorate. And so I think we really miss opportunities when we don't speak about learning opportunities and share that within the healthcare community, but it doesn't happen.
Yeah. So that case really shows the Swiss cheese model of system failure. And what that means, if you think about a slice of Swiss cheese, if you take a whole bunch of Swiss cheese and you just throw them down, the holes tend not to line up. Maybe there's a section of a hole that really lines up, but they don't really line up. It's when you have perfectly aligned cheese and it lines up, you get these holes that you can see through. And when you think about the Swiss cheese model, and when we talk about safety and systems, that really it's the system, something lined up perfectly. There was some hole that was there that perfectly aligned to allow an override of a medication, an override of a paralytic, a not monitoring. There was multiple things. I think there was even if I remember correctly, she into the medication place, she put Versed instead of midazolam. And that's what pulled up the vecuronium. And so it was even the number of letters that were required to pull
put in VE.
And had they required another letter, right? VEC is vecuronium versus VER, which is Versed. So it was even that, the amount of letters in the required to type to get out a medication. Right. And the reason I bring those up is because one is a pharmaceutical name, one is a trade name. right? And so that's why it's such a unfortunate and sad case, because there were so many points in the line that caused this thing to happen,
Yeah.
you know? And we really do, as healthcare providers, have to have that just culture, have to understand that safety is all of our responsibility, that you reporting something isn't you reporting your failure, isn't you reporting your colleague's failure, right? Like, it's very rare that we look back and say, like, well, this clearly happened because Dr. Nugent pushed the patient down the stairs, right? Like, rarely is that. And I don't want to ever have people think that I'm not saying there aren't bad actors. We know there are bad actors and people who do criminal things. I'm talking about safety events. It's rarely that a safety event comes down to one person's failure,
Right.
and so, and it's hard. I think it's really hard for us because you feel like you failed, and then you feel exposed. You feel like, oh my, everyone's going to think I'm bad at this and I'm a failure, because our training, all of medical training, physicians, nurses, respiratory therapists, physical therapists, all of our training really thrives on be the best.
Yeah.
You
And
are
don't make
right. Do not make mistakes. You have to be right. Right.
Yeah.
And so changing, I think we have to change that culture from how we teach our students.
We do. It starts there for sure. I did an article last month in LinkedIn on psychological safety, because that's such a huge component of a just culture. Is anybody should feel confident to speak up and use their voice. Dr. Jones, did you just break sterile field by, I think I saw that. And then instead of biting their head off,
No, people, you're like, wow, thank you. Thank you. I
yes,
didn't realize my hand went to that
yes,
place. And how we think about the patient and families being our team, but we also are a team. And our biggest goal is to make sure our patients are safe. Because like I've said, once they're safe, then we know we can continue to work on all of the other things. And the thing that saddens me about this conversation is that when I have loved ones, friends or family, or anyone in my personal life who reach out to me who think that the hospital is the answer, I always say, okay, but you have to make sure they're safe. Like, and this comes from someone who works in hospitals, writes about hospitals, talks about hospitals, loves my career in hospitals. And I'm always like, but are they going to be safe? And I do tell people, sometimes it'll get to a point in a hospital where I say, okay, it's time for you. I think you could be discharged, and people will feel certain ways about that. And one of the things that I bring up is being here, it doesn't always guarantee your safety. The longer you're here, the longer we're exposing you to this environment where you can get an infection, get a wrong medication, get injured in some way. There's lots of things we do to you in the hospital that also set you up to be things like confused, right? We
yeah,
give you medication, right? You may be getting pain medication, and then you're kind of groggy because you're tired. And then we also give you pain medication. You get up in the middle of the night trying to find a bathroom. And the next thing you know, you've fallen and hit your head,
yeah,
right? You're not in your environment. Particularly with our patients with dementia, dementia is a huge bucket. It's not just
yeah.
Alzheimer's. People think it's just like Nana got old. It's not just that. It's a huge bucket of things that can cause you to have this cognitive issue, and being out of their environment can really be a safety issue. And so you got to think about that. Advocate, be a part of the team, own your information, ask lots of questions. It's okay to cuss. CUSS, not SHIT. It's okay to see what you said. Concerned, right?
Uncomfortable,
Uncomfortable,
scared.
scared, and safety, right? Concerned, uncomfortable, scared, and safety. It's okay to use your cuss words. And I will tell you that your physician is trained to hear those. Like the C word, the second a nurse says to me, I'm uncomfortable. Oh, why? What's going
Yeah,
on? Family members, I'm not comfortable. Okay. They said the C word. What's going on here? We need to be a driver of your
yeah.
care, and be a driver of your safety. Yeah.
I
This has
think the
been,
other important piece to know there is for patients and families to understand there's a chain of command in the hospital.
Yes.
So if you're telling your nurse, for example, that I'm really concerned about dad, and you get dismissed and you still feel like something's going on, then you go to the charge nurse, then the house supervisor. And there's an administrator on call from the hospital 24/7, nights, weekends, holidays, or whatever. And I think people, if you understood that just because someone tells you don't worry about it and you still are, that you have a route, a next level to go to. And sometimes you need that.
Yeah. Yeah. The rapid response system is a system in the hospital where we try to respond before things get really bad, right? And that rapid response, it can be a bucket of things. Somebody is confused and then the nurse and the family don't know why and are concerned. Someone feels like they're not breathing well. Someone has chest pain, right? The rapid response system is this big bucket that we say, hey, we have to respond before things get really bad. So we're going to start. But that system came because they wanted to make sure that like everybody had a way of escalating.
A lifeline.
That's a lifeline. That system came about because it was like even family members should have a way to say, hey, pay attention, pay attention. And that was one of the ways that things get escalated. And it's a great system. It's a system that's everywhere. But it started with, hey, how do we escalate our concern that things are not right, but they're not horrible. Like we're trying to avoid horrible, right? Just because you're still breathing doesn't mean you don't need attention.
Yeah.
Right. And that's different from a code, which is like, you have stopped breathing. Your heart has stopped beating, right? We don't want that part. We want to avoid that part.
Before.
Right? Before. How can we intervene before? Right. And like, yeah. And it's not just, if you just depend on calling codes and people look at codes like TV, like code blue, and then everyone goes running, and then Dr. McDreamy comes and everyone is, it's this like TV perfect thing and the patient wakes up, but which doesn't happen most of the time. If we waited till that, then we would be like ignoring all of the other signs that someone is not well, that something needs to be addressed.
That's a really good point. The research tells us that 80% of in-hospital cardiac arrests are preventable. Mm-hmm. So what's not in the nursing curriculum, which I believe it should be in medical school curriculum as well, is failure to rescue. And that's exactly what you were talking about, is failing to recognize the signs of patient deterioration.
Yeah.
That's actually what I did my, doctoral project on. But the other piece of that is those observable physiological symptoms happen 6 to 24 hours prior to the unplanned cardiac arrest. Mm-hmm. That is so much time. And I say nurses because we're at the bedside the most, hours of the day of any healthcare provider. And if nurses aren't recognizing and truly counting respiratory rate, because we know that's the earliest and most sensitive indicator of patient deterioration. And if we miss that because they're breathing 26 times a minute, but yet we wrote down 18 in the chart,
right.
Then we've missed an opportunity to identify, hey, something's going on with this patient, before they crash.
Yeah. Yeah. We have to avoid it. The failure to rescue. You're bringing all the gems. I love it. You're bringing all the safety gems. Passwords, failure to rescue. We talked about rapid response. All of these things are just really so vital for us to understand that it also relies on the team. That if I, as a physician, am not taking your assessment as the nurse that the patient is breathing at 26, 30 breaths a minute, if I brush that off, we are failing to address something before something bad happens, right?
Yeah.
And if like you as a nurse, like your CNA comes in and is like, hey, I got these vitals that are kind of funky. And you do the same and just put them in Epic. No, it's a team effort. It's a team effort. We have to listen to everybody. We have to, have that just culture, understand we don't want to blame. We want to learn. We want to avoid. We want to build a safer hospital for our patients.
Yeah. I think in the cultures that have pointed the finger to one person, it may make them feel good in the moment, but that doesn't prevent future similar problems, of occurring again. We need to fix, as you pointed out, the Swiss cheese. If there's a hole here, i.e., there's no policy for, monitoring a patient in the CAT scan, that had a fall and hit their head. That's an opportunity. Let's put one in place,
Yeah.
and there's less chance then of potential harm happening to the next patient.
Yeah. Yeah. And if you or your family member feel that you want to discuss, you have to escalate a safety concern, you are also contributing to the work and you are helping the next family to avoid a poor outcome. And so I've had, when I was more of an administrative role, I would have family members call me after a hospital stay and, they would talk about something that happened and they really wanted to get it off their chest. And I would ask, can you formalize this? Can you write it down, write it in a letter, send it to our patient advocacy group? No, I don't want to get anybody in trouble. And I say, it's not about getting anybody in trouble. It's about you had this experience and you want to be a part of the healthcare team to teach us how to avoid the next person having the experience. Or the next time you come back, you don't want to have that happen again, do you? Like, how can we all as a community take care of each other?
And quality improvement, right?
Yeah, quality improvement. Safety is everybody's responsibility, including, patients and families should feel that they have a big part in helping to maintain it and create safety in healthcare.
Yeah. One of the courses I created for nursing education, again, is just I created Life Be Solutions for these courses to be reminders for nurses of the core concepts of the difference in oxygenation and ventilation, which is why we can't rely on pulse ox only when someone's getting narcotics, that type of thing. But, one of the things is to make sure that we're, again, communicating near misses. Because if we just say, oh, gosh, I almost gave the wrong heparin because the bottle looks the exact same, the 1 to 1,000 as the 1 to 10,000, like what happened with Dennis Quaid's preemie twins years ago. They got overdosed because the bottles looked exactly the same. But if we don't be an active participant as a healthcare provider too in those near misses, that's going to help prevent safety problems too. So we have to speak up.
Yeah. So when we talk about safety, we say, how close did this thing come to actually causing harm, right? And near miss is that we almost, thank God we missed it, but we almost caused harm for somebody. And it's a gradation that gets all the way down to actual harm. This patient is now different because of it, and yeah, all the gems, Julie. Near miss, cuss words, failure to the rescue. She's got it all today, guys. So,
well,
thank you so
I
much.
appreciate this opportunity to really speak to our audiences. Like you said, is a mixed bag of providers and patients, and I think it's just good education and information for both, because it's great reminders too of, oh, yeah, I can see why this would be important, rather than just finishing in a chaotic day, which is almost always, right?
Yeah. It's in the environment of inpatient care where things move fast. There's lots of patients. There's lots of things that you need to address. It can get to a point where people feel like they're not contributing, right? This is a big part of how you can contribute.
Yeah.
And whatever the safety reporting system is in your hospital, you should be familiar with it. The hospitals are required that you go through education to know what the safety reporting system is and how you can participate in it. But feel like what you're reporting is a good thing. You're not reporting somebody. I used to hear, thank God I don't hear it that much anymore, you can get written up. Right?
Yeah.
Like, oh yeah, you're not that's for like, that's for like camp counselors. Like, that's not how we should be thinking about it, right? We should be thinking that our patient had a near miss. Our patient had a thing that happened. I'll share a personal story since we're heading more into the personal part of the episode. But one of my children was hospitalized at a very well-known very well respected children's hospital in the ICU. And she was sick. She was on CPAP. She was, having a hard time breathing. And she was just getting a puffy, edematous. She just, to us as her parents, her two parents who are physicians, kept looking at her. This baby's just getting puffier. And that was making us as her parents, like, this isn't good. Like now she's edematous. My husband and I decided I would do nights, he would do days, right? So we ourselves switched off so he could be with her in the day. I would go home and shower. I got a phone call from him and he said, rounds just finished and there was an error. Excuse me? Her weight was off. And pediatrics doses everything weight-based. So during some point in time, it was a transition of care. The weight at the first hospital we were in was correct. The weight when we were transferred to the ICU at a different hospital was incorrect. Some point in time there, they tacked on a significant more amount of weight, which meant that when they calculated her IV fluids and her medications, everything was higher. And it was him listening to rounds, participating in rounds. When they said her weight, he said, no, she does not weigh that. And, and conversation stopped. He was able to take out his app from the pediatrician. This was her last weight. Then they went back through the records, and that could have been a big problem. And that was why this baby was getting puffier and puffier and puffier and puffier, right? And here we are in the ICU at a very well-known children's hospital that I have friends who are attending. We just left the hospital that I am an attending, and we have this error. And she was fine in the end, but that's something that's not a near miss. It actually reached the patient. It actually reached the child, right? And so when I came to the bedside in the evening, the first thing I asked was, what is your reporting system and how was it reported? And I just really want to make sure that this error, because I don't know, is there an issue between these two hospitals communicating with themselves that caused this, that we need to, look at it. And they did put it, file it in their safety event record. But I wasn't going in as the angry mom being like, you gave my baby too much saline. I was going in legitimately concerned that, had she needed something like an antibiotic, it could have been dosed way too high. Thankfully, she, the only thing that was dosed too high for her ended up being fluids and a touch of steroid. But, so, you participate. Please participate.
Yeah.
So do you have a book? I'm leading a question because I want you to say your book that you think really would drive home your message, your mission.
Yeah, I wrote it. It took me 3 years. I finished a couple years ago. You can find it on Amazon. And the purpose was, again, to inform and educate and empower patients and their families. It's got 19 chapters of hopefully very pertinent information to the layperson. We talk about how to choose your hospital, how to choose your provider, what does it mean when you're going to surgery or after surgery. And I did include 30 stories in the book. They're all true. Most of them don't have a good outcome. And the reason was because I think people really relate to stories and can say, oh, if my mom's in that situation, now I have a better understanding of what could happen or what I should do. And I think, again, not to scare people, but when we hear the outcomes that don't end well for patients, that hopefully will give you the confidence to speak up, because you could help prevent, one of those poor outcomes. And so what I decided, because a lot of people just don't read anymore, is to make an app with all that content. So that's what I'm working on right now.
Awesome.
Super excited.
Yeah, I love it. Yeah, let's make sure everyone can participate and speak up. Well, this has been a great conversation. I really appreciate your time, your expertise. And like I said, Julie hit all of the big high notes, the gems today. Please, everybody, know that you are a part of the system. Safety is key. The most important thing, if you're not feeling safe, you let us know. You really, really want to focus on maintaining safety through a hospital stay. This has been a great conversation, Julie. Thank you so much for joining us.
Thank you. Appreciate you having me on.
Yeah, and thank you for everyone listening to the Prescription for Admission podcast. I'm your host, Dr. Monique Nugent. I'm also the author of the book Prescription for Admission, where I talk about a lot of these other topics, and I have a lot of tools in there that can help you learn about hospitalization and prepare yourself for a hospitalization. If you're listening to us on Spotify, you can also listen to us anywhere you find podcasts, like the Apple Podcast app and YouTube, where you should go and like and subscribe. So thank you, everybody, and we'll see you later. Have a good one. Bye.